Okay, in the interest of time, I think we'll get going. So welcome again, everyone. My name is Rebecca Armstrong. I'm the manager of patient education programs for the Canadian Breast Cancer Network. And thank you for joining us for today's webinar on advancements in care for early stage breast cancer. Before we get started, I'd like to cover a few housekeeping items. This session is being recorded and will be available on our website for anybody who may have missed it once the session ends, and I'll send out a link when that recording is available. You'll also find previously recorded webinars that address a variety of different topics on our website at www.cbcn.ca. I'd like to extend our sincere appreciation to our sponsors for the session today, who've provided support through unrestricted educational grants. Novartis, our gold level sponsor, Pfizer and Gilead are silver level sponsors, and AstraZeneca, Merck, and Daiichi Sankyo for our bronze level sponsors. The format for today's session will be a presentation by our expert speaker, followed by a question and answer period. Please feel free to submit your questions throughout the session using our Q&A function that you should be able to find at the bottom of your screen. I'd like to now welcome our host for the session, Kathy Amendolia, the chair of the board for the Canadian Breast Cancer Network.
Thank you, Rebecca. Welcome again, everyone. Thank you for joining us today. I am pleased to welcome and introduce our expert speaker, Dr. Nancy Nixon. She is a full-time medical oncologist at the Tom Baker Cancer Center and assistant professor at the University of Calgary. She specializes in treatment of breast cancer and is the Southern Alberta Tumor Team Lead for Medical Oncology. We are incredibly appreciative of all the time Dr. Nixon offers to the patient community by joining us here today. Dr. Nixon, it's great to see you, and thank you for being here today.
Thank you, Kathy, for that introduction. I will share my screen here so that we can look at my slides, and let me know if anybody has trouble seeing this. But today I was asked to present on advancements in care for early stage breast cancer. And so just to set the stage a little bit, I will review some of the latest information about new and emerging treatments for all types of early stage breast cancer, and then discuss a little bit of clinical trial data for all three subtypes of breast cancer to sort of help understand what the treatment landscape looks like currently and where we expect it to go in the future. So I did prepare this as a case-based discussion. So case number one is a 56-year-old previously healthy woman. She has no family history of breast cancer and just presented for a routine screening mammogram. Her breast imaging showed a 2-centimeter abnormality in the breast and a suspicious axillary node. The biopsy of this showed that it was ER strongly positive, PR strongly positive, and HER2 negative. So, of course, it's very important for us when we're talking about treatment of breast cancer to decide what type of breast cancer we're dealing with. When I meet with patients, I always say that adjuvant treatment is largely preventative, as the main goal of our treatment is to prevent breast cancer from coming back, with surgery being the curative intent procedure. And so when we're considering how much preventative treatment to offer women, we have to really think about how risky is it that the breast cancer could come back. So there really are 5 main intrinsic molecular subtypes of breast cancer, and I put them up here. In practice, we divide them more into hormone receptor positive, HER2 positive, and triple negative. But you can see that if we look at these different subcategories, approximately 2/3 of our patients will have hormone receptor positive breast cancer. About 20% will have HER2 positive breast cancer, and then about 15 to 20% will have triple negative breast cancer. So for this particular case, she's referred up front to see a surgeon. She has breast conserving surgery right away and has a 2.5-centimeter tumor with 2 out of her 3 lymph nodes being positive. They go on to look at the grade of the tumor, and it's found to be a grade 3, which is a high grade for a breast cancer, and a Ki-67 of 21%. Her oncologist also orders an Oncotype DX, and that comes back with a score of 32. So what is Oncotype DX? This is a test that we use very commonly in breast oncology. What it does is it looks at the expression of 21 genes in the tumor itself, and based on the expression of those genes, produces a score between 0 and 100. This score is both prognostic and predictive. And the difference between these two things is pretty important. So prognostic information tells us, based on the natural history of a breast cancer, how risky is it? Predictive information gives us very important knowledge on how we expect that breast cancer to respond to treatment. And the way that they developed the predictive nature of this test was actually with two randomized clinical trials that were prospective, meaning they randomized women to different treatment arms and followed them over time. The first is called Taylor-X. So this was initially published in 2018. And what this study did was looked at the use of oncotype for determining the benefit from chemotherapy. So they took women with hormone receptor positive breast cancers that were node negative, and for women who had an intermediate score, so a score between 11 and 25, they randomized them to either receiving chemotherapy or endocrine therapy alone. And what they found was there was essentially no difference. So when we look at the top graph there, that's looking at disease-free survival, meaning a woman having either a distant metastatic recurrence or a new primary breast cancer. And you can see that those two lines are completely crossing or completely superimposed on one another. The second graph there shows the distant recurrence, meaning the event of having a metastatic recurrence. And similarly, the curves are completely crossing. So there was certainly no benefit for these intermediate risk oncotype scores of additional chemotherapy. So this is really important because historically for women who had breast cancers over 3 centimeters, we would offer them chemotherapy just based on risk stratification based on size. Now we're sparing women chemotherapy, and we're also able to identify women who have smaller tumors but that are at higher risk. So subsequent to this, they did another study called RxPonder. And this was using that same oncotype test, but in node positive women. So they took women with hormone receptor positive breast cancer that had 1 to 3 lymph nodes positive, or N1 disease, and similarly randomized them to receive either chemotherapy plus endocrine therapy or endocrine therapy alone. What they found in the overall population, and especially in the postmenopausal population, was that again, there was no benefit from chemotherapy. And so while our previous standard of care was to offer all node positive women adjuvant chemotherapy, we can see that for patients who have a low genomic risk, there's no benefit, and they can have just endocrine therapy alone. What was different in this study was that for premenopausal women, there was in fact a benefit from chemotherapy. So you can see here a separation of the curves looking at invasive disease-free survival with an absolute difference of about 4%. So the benefit of preventing recurrence, including a breast recurrence or a distant recurrence, was 4 to 5% in the premenopausal women group. Now, a question that remains unanswered for this population is how much of that benefit from chemotherapy is based on the fact that chemotherapy also suppresses ovarian function? There's been other studies that have come out since this was first designed that showed for premenopausal women, if we use ovarian suppression plus endocrine therapy, it's better than endocrine therapy alone. Only about 14% of these premenopausal women actually received ovarian suppression as part of their treatment. So unfortunately, the question still remains, was this difference in benefit from chemotherapy itself, or was it the effect of chemotherapy on their ovaries? And so there is an ongoing study now to help us answer this question. So this particular woman, because she had node positive disease and a high risk oncotype score, was given chemotherapy with docetaxel and cyclophosphamide. She was started treatment with an aromatase inhibitor and discussed a plan for 5 to 7 years therapy, depending on her tolerance and bone health. 3 months later, she sees her oncologist again, and she's tolerating treatment quite well. So she sees her oncologist about adding abemaciclib. So abemaciclib is a CDK4/6 inhibitor. And what are CDK4/6 inhibitors? So you may have heard about them because they've become our new standard of care treatment for advanced or metastatic breast cancer. The way that they work is by inhibiting cell turnover. So this slide just shows how estrogen binds to the estrogen receptor, comes into the cell, and ultimately causes proliferation of DNA as a transcription factor. CDK4/6 inhibitors block this pathway with cyclin D that allows cells to enter the cell cycle turnover. So it sort of blocks cell proliferation and works really well in combination with endocrine therapy. So for the past number of years, we've been using them as our standard first-line therapy for metastatic disease, but more recently have moved them into the curative setting, so into adjuvant treatment. Monarch E was one of the first studies we saw that used these agents in the early setting. So Monarch E was a study that took hormone receptor positive, HER2 negative early breast cancer. They were node positive as well. They were randomized to receive either abemaciclib for 2 years, plus their standard of care endocrine therapy, or endocrine therapy alone. They did stratify their population into 2 cohorts. So the first cohort was high risk based on clinic and pathological features. So these were women who had at least 4 axillary nodes positive, or could have 1 to 3 nodes positive and had to be at least grade 3 and a tumor size greater than 5 centimeters. Cohort 2 was considered high risk based on Ki67. So this cohort had 1 to 3 axillary nodes positive, and a Ki67 greater than 20%. So what they found was there was a benefit from including abemaciclib as part of their adjuvant treatment. And importantly, that benefit extended beyond the completion of abema. So you could imagine, after these 2 years, you would worry that you would only see the benefit while people were on treatment, and then when their treatment ended, that benefit might get lost. But you can see that the benefit continues and continues to grow with further time off therapy. One frustrating thing about this study was that this benefit was observed in the intention to treat population, meaning both cohorts 1 and cohorts 2 had the same benefit. When they initially sought approval from FDA and Health Canada, it was made dependent on Ki67. So up until recently, both in the US and Canada, you had to have a Ki67 greater than 20%. Health Canada and the FDA have since changed that to be inclusive of the entire study population, but we're still kind of working on getting our funding model to catch up to that. So in the meantime, there is an access program for some of those patients who just don't meet that one criteria, but it's been a little bit of a nuisance to try to get patient access to this medication. Now, around the same time or slightly after that study was the NATALY study. Now, this is another really important study. So ribociclib is another CDK4 agent that we use commonly in metastatic disease. It's our standard of care first-line therapy. And they did a very similar study, but some important differences here. So the patient population they enrolled was a lower risk population. So they included stage 2A patients, meaning node negative patients. But if they were node negative, they had to have some other high risk feature. For example, grade 3 or a high oncotype score or high Ki67. And these women were randomized to receive adjuvant aromatase inhibitor or their aromatase inhibitor plus 400 milligrams daily of ribociclib for 3 years. So the abemaciclib study looked at 2 years of adjuvant treatment. This is an additional 3 years of treatment. Now, when we do use this drug in the metastatic setting, we typically prescribe it at 600 milligrams. So this is a slightly lower dose than what we would typically use. Their primary endpoint was invasive disease-free survival, but also looked at recurrence-free survival, distant disease-free survival, overall survival, and then some important safety and tolerability outcomes. This was presented initially at ASCO last year, And this is with quite short follow-up. So this is a fairly early study. And while they presented it as being highly significant, in the sense that it did show a benefit statistically, the absolute difference in terms of preventing disease recurrences was about 3%. So, I guess highly significant is up to the interpretation of the person looking at the data. They did have a little bit of further follow-up. They didn't this year present any new data, but they did show further follow-up in the group of patients that were node negative to show that there was still a similar benefit in patients in spite of having node negative disease. Part of the unanswered questions we have about this is, will the lower risk population included in this study still have the same benefit as our abemaciclib type group that has really high risk disease? And this sort of demonstrates that it looks like they might. Now, this, of course, has pretty significant implications on our healthcare system. Just adding in an additional targeted therapy for a really big group of women, I think it's important that we understand who is most likely to benefit. So just to summarize what I've said about the hormone receptor positive group, genomic signatures provide important prognostic and predictive information that for many patients guide our treatment decisions. Adjuvant CDK4/6 inhibitors are being incorporated into care, but we have to remember that careful patient selection is key. There are some toxicity differences between these two agents. Abemaciclib has fairly significant diarrhea, and it can be a challenge to keep patients on this successfully while maintaining their quality of life. And then, of course, these are agents that we have to monitor blood work for monthly or every 3 monthly because it can cause neutropenia. And so, to be on an agent for 2 or 3 years that requires such close monitoring is certainly a change in our current practice. So moving on now to case number 2, the initial presentation here is the exact same. So this is a 56-year-old woman, no family history of breast cancer, and presents for a routine screening mammogram. Again, she has a mammogram and an ultrasound that shows a 2-centimeter abnormality in the breast with some suspicious axillary nodes. The difference here is that her biopsy comes back as being triple negative, so ER negative, PR negative, and HER2 negative. And so already she's following a little bit of a different trajectory. So instead of seeing a surgeon, she's referred directly to a medical oncologist for discussion of neoadjuvant systemic therapy. She gets tested for germline BRCA mutation testing and is found to be BRCA1 positive. So why do we use neoadjuvant therapy? Historically, the main reason we would do this would be to downstage local disease and help facilitate what is the curative intent surgery. The initial study that looked at neoadjuvant therapy was to show that essentially whether you do chemo before or after surgery, it's equally effective at preventing the distant recurrences. But now it's really important that it allows us to observe tumor response to our systemic therapies and allows us to tailor subsequent treatments. And why this is important is because we know that a patient's response to neoadjuvant treatment does tell us a lot about their long-term outcomes. So this was a study or an analysis, I guess, that looked at pooled data for old studies looking at neoadjuvant treatment, which I had discussed was our previous sort of benchmark to say, does systemic therapy work better before or after? And it was the same. And what they did observe was that patients who had a complete response did do better longer term. So achieving that was meaningful. And so we've started to use this information to help us understand how we can sort of stratify patients as to who needs more or different treatment after surgery. So with triple negative breast cancer, we use immune therapy now. And what is immune therapy? So this diagram just kind of helps explain to us what it is. You can see the pink cancer cell has this little orange protein called PD-L1. This protein is important because it interacts with T cells, which is an important cell in our immune system, and tells the immune system to recognize it as self, meaning tells your immune system to ignore it and not pay attention to it. Keytruda, which is pembrolizumab, blocks this interaction, so it prevents the cancer cells from hiding from your immune system and allows the T cells to activate and attack the cancer cell itself. So this has been used in many tumors. We've seen immune therapy in melanoma initially, and more recently, we've seen it move into kidney cancer, lung cancer, all sorts of cancers, and now is being used as standard of care for triple-negative breast. So this was the landmark study that looked at the addition of neoadjuvant or preoperative pembrolizumab to chemotherapy. So patients were enrolled if they had any tumor greater than 2 centimeters or tumors less than 2 centimeters but node positive. They did sample for PD-L1 expression, but it was not required to be enrolled on the study. So patients received either chemotherapy plus pembrolizumab or chemotherapy alone prior to surgery. After surgery, they went on to receive either pembrolizumab to complete the duration of a year or placebo. Now, importantly, what they observed was that there was a significant increase in terms of pathologic complete response. So for patients in the entire population, you can see that complete response rates went from about 50% to close to 65%. And this seemed to be regardless of PD-L1 expression. So overall, the PD-L1 negative patients had worse response, but they still benefited from the addition to chemotherapy, by the addition of immune-based therapy. And this improvement in PCR, or complete response rate, translated as well into survival. So this is showing that there were fewer recurrences in the patients who received pembrolizumab. So this patient had that regimen. She had her chemotherapy and immune therapy, and then based on her BRCA mutation status, underwent bilateral mastectomies. At the time of her surgery, she had 0.8 centimeters of residual disease in the breast, and one lymph node had a micrometastatic deposit. So you'll remember I had said for those patients who don't achieve a PCR, we know they are at slightly higher risk of a recurrence. So how do we manage that risk? CREATE-X is a comparatively old study that looked at adding adjuvant capecitabine, an oral chemotherapy drug, for patients with breast cancer after preoperative chemotherapy. So they took women, both hormone receptor positive and triple negative, and randomized patients with residual disease following neoadjuvant treatment to either capecitabine or observation. And what they found was that there was a benefit here in the addition of capecitabine as an adjuvant treatment. That benefit was greatest in women who had triple negative disease. And so it's been our historical standard of adjuvant treatment for women with residual disease following neoadjuvant chemo to provide capecitabine. More recently, we've seen data from the Olympia study. So this looked at adjuvant olaparib for patients with BRCA mutated breast cancer who are at high risk of recurrence. So BRCA mutations essentially mean that patients have lost a gene that codes for DNA repair. So the reason that they're at risk of cancers is because when they have breaks in their DNA, it's not repaired properly. Olaparib is a PARP inhibitor. And so it causes damage to a different mechanism of DNA repair, such that when a patient has a BRCA mutation and also has a PARP inhibitor, it leads to synthetic lethality, meaning these cells are unable to grow and proliferate out of control. They're just unable to divide at all. So Olympia showed that there was a benefit from adding adjuvant PARP inhibitor. So you can see this was in patients both with hormone receptor positive and triple negative breast cancer who had a BRCA mutation that had a incomplete response. So the benefit in terms of disease-free survival was about 8%, which is meaningful. And similarly, distant disease-free survival was about 7%. It's still early, but we already see a 3-year overall survival advantage, meaning that this is helping women to survive because of having been on this drug. So for triple negative breast cancers, neoadjuvant pembrolizumab is the standard of care for all tumors over 2 centimeters, irrespective of their PD-L1 status. That's different in metastatic disease, where we require PD-L1 positivity to be eligible for treatment. The best adjuvant therapy remains uncertain. So I've shown you data from the CREATE-X study and from the Olympia study, and also said that patients who were treated on that Keynote study received a year of adjuvant pembrolizumab following their initial treatment. Now, there's no data showing all of these used together. So for patients who have significant residual disease following their neoadjuvant chemotherapy, we are unsure as to whether we should do a combination of pembrolizumab plus capecitabine. If they're BRCA1 positive, should we also add in olaparib? Currently in Canada, we're a bit restricted in terms of how we can use these agents in combination, just because it's sort of a data-free zone. But I think hopefully we'll learn more about this because our colleagues in the US are combining these agents, and hopefully we'll be able to use some real-world data to advocate for that as being our standard of care as well. Okay. So case number 3. Now this is a 56-year-old woman with no family history of breast cancer presenting for routine screening. She also is found to have a 2-centimeter abnormality in the breast and a suspicious axillary node. Her pathology comes back as ER positive, PR negative, and HER2 positive on IHC testing. So again, for our HER2 positive breast cancers, we're relying on neoadjuvant therapy to help observe the tumor response and tailor subsequent treatment. So similarly, she gets referred to a medical oncologist upfront and is given neoadjuvant chemotherapy with docetaxel, carboplatin, and trastuzumab. She undergoes a breast conserving procedure and is found to have 1 centimeter of residual disease in the breast and 2 millimeters of disease in one of her axillary nodes. So you may have heard a lot of discussion recently in the oncology world about drug antibody conjugates. So these are really powerful agents, and what they are is an antibody molecule that's attached to a chemotherapy drug. So for TDM1 or trastuzumab emtansine, it's a HER2 antibody or a trastuzumab antibody connected to an emtansine molecule chemotherapy. So it binds to HER2, is internalized into the cell, and is degraded into the lysosome. During this process, the chemotherapy molecules are released directly into the cancer cells. And so it's a very targeted delivery of chemotherapy. So this was not a super recent study, but we did see further follow-up from a really important study called the Catherine trial at San Antonio last year. So this was a phase 3 study looking at TDM1, that molecule I just showed you, versus trastuzumab for residual disease following treatment for HER2 positive breast cancer. So the patient that I presented to you received neoadjuvant chemotherapy plus trastuzumab prior to surgery. Our historical standard of care would have been to continue that trastuzumab on its own for the duration of a year. This study looked at continuing trastuzumab alone versus switching to TDM1 as the adjuvant portion of treatment. So they took women who had at least 6 cycles of chemotherapy, including trastuzumab, and had to have residual disease in either the breast or axilla. They were randomized to receive TDM1 versus trastuzumab. Their primary endpoint as well was invasive disease-free survival, but had the key secondary endpoints of distant disease-free survival, overall survival, and quality of life. It was initially presented in 2018, and with shorter-term follow-up, they did see an impressive difference in terms of 3-year invasive disease-free survival. You can see a difference of over 10% in terms of preventing breast recurrences. At that time, overall survival was not yet significant. But what we did see with longer follow-up is that invasive disease-free survival continued to improve. So after 8 years of follow-up, they saw a 14% benefit in terms of invasive disease-free survival. And importantly, a decrease in CNS recurrences. So unfortunately, for our women who have HER2 positive breast cancer, the brain can be a site where this type of breast cancer can recur. And so the addition of TDM1 showed us significant decreases in the number of CNS events. And then with further follow-up, they did observe a statistical and clinically meaningful benefit in terms of overall survival with a benefit of about 5%. But there are new and other options to improve on this even more. So you may have heard about a drug called neratinib. So this is an image to show how neratinib works. So what we've talked about in terms of HER2 has mostly been antibody binding to this extracellular domain. The way that HER2 actually causes cell proliferation is by binding to itself. So different than the estrogen receptor, which binds estrogen, the HER2 receptor just binds to itself and activates this downstream signaling pathway that tells cells to grow and proliferate. So neratinib works on the intracellular domain. It blocks that signaling through the cell. And so for tumors that may not be super sensitive to the extracellular type of block, it's kind of hits them from a different angle. And so there was another study that looked at using this in the curative intent setting. So the ExteNet study took women with early stage HER2 positive breast cancer, and they had to have at least one chemotherapy and trastuzumab-based therapy within the past 2 years. They were randomized to either 1 year of neratinib or placebo. Their primary endpoint was invasive disease-free survival. It's highlighted here that there was no mandatory diarrhea prophylaxis on this study. The reason that's highlighted is because without prophylaxis, diarrhea was a very common and significant toxicity. And so since that time, we've started to routinely use a preventative antidiarrheal agent. What they demonstrated that in the intention to treat population was that there was a benefit, about 2.5% in terms of preventing an invasive disease-free survival event. But there was not a benefit seen in terms of overall survival. This is a forest plot, which basically just looks at subgroups to say which group of patients seemed to benefit the most. And from this, what we see is that it was the, interestingly, hormone receptor positive group that demonstrated the largest benefit. And so we've started using neratinib for patients who are triple positive and who do not achieve a PCR. So to summarize this population of women, neoadjuvant systemic therapy is the standard of care for tumors greater than 2 centimeters. Adjuvant TDM1 has been a very important change to our treatment, and we've seen meaningful improvements in disease-free survival and now overall survival with extended follow-up. Neratinib, as you can see, the benefit was maybe a little bit less significant, but certainly something that we can consider adding for our patients who have high-risk triple-positive disease as an extra tool in our toolkit to prevent breast cancer from coming back. So to summarize, I think, the takeaway message from this is that the treatment of early stage breast cancer is evolving, and it's evolving to tailor treatment according to risk. And so we're learning more about how we can understand what a patient's risk is up front and how we can choose appropriate therapy based on that. For hormone receptor positive patients, we need to understand more about the benefit of chemotherapy versus ovarian suppression for our premenopausal patients, and try to understand who will be benefiting most from adjuvant CDK4/6, because it is a significant shift in our practice to keep these women on active agents that require frequent monitoring for 2 to 3 years without really identifying who's going to be the patient that benefits. For our higher risk diseases, we're seeing novel agents, novel therapies, and a lot of the ongoing studies are looking at how we can use these in combination and ideally find chemotherapy-free regimens. And so you can see that in the studies that I've presented for triple negative and HER2 positive breast cancer, chemotherapy remains our standard of care, just because we know that this is a higher risk type of disease. With how successful we've seen immune therapy be, with how successful some of these newer drug antibody conjugates are, we're hopeful that we could find some combinations that maybe help us avoid chemotherapy for those groups as well. But those studies are ongoing. And I'm happy to answer any questions that have popped up or any more that may continue to pop up.
Okay, I'm back. Thank you very much. That was a lot of information, and we're starting to get questions. I'm going to start with some questions that I already have. I'm going to go with a question about your cases all had 2 centimeters after routine screening.
Yeah.
My question is, I think women go mammogram 2 years if
Yeah.
you have nothing, okay? Does that mean that all biologies of these tumors grow to 2 centimeters in that short amount of time?
No, that's a good question. So the reason I presented it that way was to highlight how for the same presentation, the treatment would be quite different. Um, the triple negative HER2 positive breast cancers would grow more in between surveillance imaging if you were to look, time point to time point. The guidelines have updated for women over 50 to have screening imaging every 2 years, but we know younger women who are at risk of having a more aggressive biology, we're still screening once a year for that reason, because they're more likely to have a tumor that may grow a little bit more quickly.
Right, right. Okay. That's good. I have another question. So when we're talking about oncotype, to decide even how to treat the patient, where does family history, just family history of families that have whatever cancer, does that still routinely asked, and how much does that influence how you treat a patient these days?
That's a very good question. So the main purpose of asking about family history is to understand their risk of having a mutation. And by that, I mean, whereas Oncotypes looks at gene mutations in the tumor, asking about family history depends more on, was I born with a gene mutation that predisposed me to getting cancer? And so typically it does not change our treatment, right? We still treat the cancer that's been diagnosed the same. We just manage their future risk differently in terms of more advanced screening for breast. So you would be getting breast mammogram and MRI, or have a prophylactic mastectomy like the woman in my prompt. And then similarly, we would manage their ovarian cancer risk differently.
Okay.
The only caveat to that is the adjuvant olaparib in that Olympia study that I presented, because that agent is particularly useful in women that have a BRCA gene mutation.
And is it are patients with family histories presenting with more serious biology of their tumors,
Yeah.
or is that it doesn't make a difference? And
It,
their overall survival, does that get affected as well?
right. So, for example, the women who we know to be at higher risk of having a BRCA mutation would be very young women, women who have a very strong family history, and women with triple negative breast cancers. So like BRCA mutated breast cancers are more likely to be triple negative versus a population average. So that's why we screen women with very strong family histories for mutations like this, because we think, oh, this could be related.
Okay. I have another questions about the nodes. So, when you enter people under certain treatment, it's node positive, either nothing or some nodes.
Mhm.
Are nodes that start in one lymph nodes microscopic, very just early, are those considered a node positive, or are they considered not, or do they fall in a gray zone? How do you treat people with that diagnosis?
So there is a spectrum, right? So there's such thing as isolated tumor cells. Occasionally, they'll see a few cells in a lymph node, and that is not the same as having a positive node. There's also such a thing as a micrometastatic deposit, which is less than 2 millimeters, and so that is um, in between, like kind of in the gray zone. But we typically group those people with node positive disease. So sort of knowing they're probably less high risk, but still treat them as if they're truly node positive.
Okay. And for triple negative, we know that, we're hoping for a treatment that is designed for triple negative. And eventually maybe they won't need any, chemotherapy. Does that mean that how much are we over treating patients? Not that people wouldn't want to get treated, but do you think that we would find out that a lot of these women are treated, but maybe not necessarily needed to be treated?
Yeah, good question. So I don't think we're over treating them, to be honest, because I think partly because we haven't found the proper chemotherapy sparing regimen. So it is, I think, for patients who are diagnosed with a triple negative breast cancer who meet me that are node negative, relatively small tumor, and then I describe to them what that neoadjuvant immune therapy protocol looks like, are quite surprised by how much treatment I'm offering them based on how small their tumor is. But the reason for that is because we know that the intrinsic nature of triple negative breast cancers is to be aggressive. And so, reassuringly, that it works really well, to be honest, that regimen. I've had a lot of patients with complete responses, and it's very satisfying, but also quite toxic. And so they're looking at some other drug antibody conjugates. So I had met the one I mentioned, of course, was targeted to HER2, but there are other proteins that can be targeted on triple negative breast cancers that have that chemotherapy attached to them, which hopefully will allow us to kind of lessen our heavy hitting chemo drugs.
Okay. And speak a little bit about the adding to already the standard of care for HER2 positive, not HER2 positive, hormonal positive early stage breast cancer. So now, because I would imagine people are recurring later on in life, we want to ensure that they don't. So we're adding other therapies.
Mhm.
How well do patients take all these medications, and what is the success of keeping these patients with all these drugs for an extended period of time?
That's a really great question. So, hormone receptor positive, I've kind of discussed as if it does stage for stage have a more favorable prognosis. But the tricky thing about it is that it has the ability to recur late and to come back many years and decades into the future. And so it does mean extended adjuvant treatment, right? So being on an anti-estrogen based treatment for 5 to 7 years, sometimes even more, and then additional years of targeted pills. And so, it is a lot of treatment, and it's very hard to stay on treatment that causes toxicity for that amount of time. And so a lot of my patients on adjuvant endocrine therapy, it really is balancing toxicity versus benefit, right? And just saying like how far can we really push these things before the 2 to 3% looks a lot smaller, right?
Right, right. Okay. Can I ask a question outside the medicine? What
Mhm.
about exercise?
Oh
Is
yeah.
that a prescription?
So it should be, to be honest. So exercise has numerous benefits in adjuvant treatment of breast cancer. So there's never been a specific diet to correlate with better outcomes, but we do know that women who maintain a healthy weight do better longer term. And so it seems less important how do you achieve that weight versus maintaining a lifestyle that allows that. And so typically, like an exercise prescription that I would offer patients would be moderate activity, 30 to 60 minutes for 3 to 5 days a week. And so it doesn't have to be like you're doing an hour of high intensity fitness a day every day, but incorporating exercise into your life is important. It also helps with some of the toxicities of therapy. So certainly a lot of data to support that the arthralgias associated with the aromatase inhibitors are less with exercise.
Okay, great. I'm going to take some questions that came in through the live questions. So first question, this person asks, if you have a certain subtype when first diagnosed, if you have a recurrence, will it likely be the same type?
Yeah, good question. Not always, actually. So we do routinely retest if a person has a recurrence to see if it's the same. The most common change we would see is someone from going hormone receptor positive to hormone receptor negative. Um, but it's not always the same, is the short answer.
Right. So I guess it's different, right?
Yeah, so the reason that can happen is, as you can imagine, within like a tumor, there's lots of different cells. And so within a tumor, there's tumor heterogeneity, meaning like some parts of the tumor would be more hormone receptor positive, some would be less. And so it sort of depends on what ultimately leads to that recurrence to say what the recurrence will look like.
Okay. The other question that came in was about Oncotype DX score. Does everyone get one?
No. So the people who we routinely order it on are people who would have fit that trial criteria in either the Taylor X study or the RX Bonder. So for our provincial criteria for node negative, hormone receptor positive breast cancers, they have to have a tumor over a centimeter. Um, for node positive oncotype, we typically only order it in postmenopausal women because our standard of care for premenopausal women remains chemotherapy, regardless of what that score is. And then, of course, if they fall outside of the trial criteria. So, for example, if you have many nodes positive, we wouldn't order it. If occasionally you see patients who are very weakly hormone receptor positive, meaning like barely hormone receptor positive, oftentimes we would treat those people with chemotherapy without an oncotype, but also their oncotypes are typically very high. So we usually order it anyways.
So Oncotype DX testing are not just used for HER2 negative patients, right?
Yeah, they
Or,
are. Like HER2, they're only hormone receptor positive, HER2 negative.
and patients, but not the HER2 positive.
No.
That's the question that came in. Can you clarify that? Because I'm confused now with that question.
The only people we use oncotype for is hormone receptor positive, HER2 negative.
Okay, okay. And what's considered a high oncotype score? Can you explain a little bit about the score and also elaborate a little bit about when it falls into gray zone, how a doctor decides what to do? How do you speak to your patient? How do you, put together what they should be doing and what they should be looking at? Because that's something that frightens people if they fall into that gray zone area.
Yeah. Yeah, and that's like the art of medicine, I guess, right? So, like across the board, a score over 25 is considered high risk. In node positive disease, our threshold is a little bit lower. And then I had mentioned like there's this caveat with premenopausal women, right? So even in that study, I said that the intermediate score was 11 to 25. When they did a subgroup analysis of premenopausal women, there was some benefit between 16 and 20. So the benefit for premenopausal women started to appear a little bit earlier than it did for postmenopausal women. And by earlier, I mean at a lower score. So sometimes we have conversations with premenopausal women with scores between 16 and 20 to say, this is kind of on the cusp. How should we manage this? What nobody knows was that benefit because of the ovarian suppression effect of chemo, right? So when we give premenopausal women chemo, it often induces an early menopause, or was it the chemo itself? So we could probably achieve a similar effect by just using an ovarian suppression medication like Leuprolide, but that clinical trial is ongoing. So we will have that answer. We just don't have it right now. So that's when shared decision making really comes into play. I think, when we say that the risk and benefit is kind of like this, it becomes very patient dependent. And so if I can give you examples of things that would steer a person one way or another, a premenopausal woman that's 49 is different than a premenopausal woman that's 32, right? We would treat the 32 one probably more aggressively. Similarly, we have to consider what are the really worrisome toxicities of side effects. So, for example, like our common regimen would be a taxane type drug, which can cause neuropathy. That neuropathy can be permanent. And so, if it was a person who relied on their fine motor skills for their livelihood, their willingness to accept that risk would probably be less than someone who, didn't require to be using their fine motor skills every day. So that it does become very individualized as to what risk is, how that risk affects their life, and how big that benefit has to be for them to accept that therapy.
Okay. And what about those who don't score high, but still want to be super conservative and go ahead with treatment?
Well, so I often have this conversation, and it's a tough one, right? Because it's hard not to make fear-based decisions when you're kind of at the scariest point of your life. And so I think we have to not keep breast cancer blinders on, but consider how these treatments are going to affect your long-term health. And so, it's very hard to not want to make a fear-based decision when you're in the moment, but then, 10 or 20 years later, when you're still having trouble opening jars because your neuropathy isn't great, it would be harder to reconcile with that decision, I guess. So it's very hard to offer a toxic treatment if we don't believe that there's going to be a benefit.
It is. But I can imagine some want to be very, very,
Yeah,
do everything they can, just same as the mastectomies
right.
when not,
Yeah.
necessary.
Mhm.
And it's fear, I guess it's fear driven, and depending on
Yeah.
the age of the,
I think that's kind of a different discussion. Um, just because it is survival outcomes are the same, but I certainly have women in my practice who um, have breast conserving surgeries who may then have abnormal mammograms that may be benign but lead to biopsy, lead to anxiety like throughout the course of their life. So that I think is a little bit different in terms of what the benefit of a mastectomy is, but that again is a very personal decision.
right, thanks. I have another question here. Almost everything you buy these days has a reference to soy, lecithin may contain soy or contain soy. What is
Yeah,
the danger for those who have hormone receptor breast cancer?
yeah,
And
that's
I
good.
guess the consumption of soy.
Yeah, we get asked this a lot, right? So the reason why people talk about that is because soy is like an estrogen mimic in theory. There's never been any data to show that consumption of soy worsens breast cancer outcomes. So it is like a more of a theoretical risk. And the dietitians that I work with certainly do not tell people that they have to eliminate soy from their diet. But if we try just to say anything in moderation should be safe. And so um, like if you encounter soy sauce or like have a soy latte, that should not impact your breast cancer outcomes. But if you went on like a purely soy diet, then theoretically it could be a problem. But the dietitians that work with us typically don't say strictly to avoid it.
Right. What about, okay, do you have information you can speak to the treatment approach for metaplastic triple negative breast cancer? This is an extremely rare and aggressive breast cancer. Even at an early stage, tumors are always grade 3.
Hmm. Yeah, so this is like it's sort of like a subtype of triple negative breast cancer. And we treat them the same as we would any triple negative breast cancer. Um, eh, just knowing that the biology is aggressive, as most triple negative breast cancers are, we have the same approach. There aren't any agents dedicated specifically for metaplastic breast cancers, so they are kind of grouped into that larger triple negative um, category.
So what is metaplastic triple negative? How different does it work? Does it
Uh,
um
so what it is basically is like the cells look less differentiated. meaning like they have more messiness in their DNA, which then, based on the way that tumors become tumors, make them a little bit more aggressive, right? Just because they are de-differentiated, um, but they are still treated the same.
Okay, and does everybody get tested to see if that's the case for them?
Yeah, it would be something that the pathologist would comment on when they're reading the pathology.
Okay, okay. So this next question, how soon after neoadjuvant treatment is surgery recommended?
Good question. So it depends a little bit on like recovery from your previous cycle, but usually it would be like 6 weeks, 4 to 6 weeks, that we would want to have surgery without going much beyond that.
And if you go beyond that, would it
So,
make a difference in the prognosis?
with like triple negative and with HER2 positive, if we're worried that it's going to be longer, you could still have like a single agent, either pembrolizumab or trastuzumab, to kind of like bridge the time between surgery. So for example, if I have a patient whose surgery is 6 weeks out, they'll finish their chemo. 3 weeks later, they'll have just trastuzumab on its own, and then they'll go for their surgery. So I wouldn't leave someone completely off treatment for longer than that, so that they're still getting systemic therapy during that little gap.
Okay. And the next question again is on oncotype. Can you discuss what happens with an oncotype of 43? This person says she's been through adjuvant chemotherapy, and what's next for her?
Mm-hmm. So it would depend a little bit on her age, but after chemotherapy, we would give endocrine therapy. So anti-estrogen therapy for premenopausal women with a high-risk oncotype is usually ovarian suppression, meaning like leuprolide injections plus an aromatase inhibitor. For postmenopausal women, it would be an aromatase inhibitor. I guess the question of a CDK4/6 inhibitor that I had mentioned would depend on whether or not they had node positive disease. So right now, abemaciclib is the agent that we have approved, but it's only approved for node positive disease. Ribociclib, which I talked about, is not yet approved, but if this were 6 months from now, it may be a consideration. But right now, we're just using abemaciclib.
Okay. The next question is, should PR negative lobular breast cancer or invasive ductal carcinoma be treated differently?
Should which?
PR negative lobular breast cancer or invasive ductal carcinoma be treated differently?
So invasive, like lobular and ductal carcinomas, do behave a little differently. Oftentimes with lobular, it's missing a protein that is called E-cadherin. So we see ductal breast cancers growing more like kind of like balls, and lobular breast cancers growing more like sheets. And so sometimes what you'll see with lobular breast cancers is what the imaging says versus what the pathology says is not the exact same. Like sometimes we see that after it's removed, the tumor is actually a bit larger than what we had thought it had been on imaging. There is some data to show that lobular breast cancers are maybe more sensitive to certain treatments like aromatase inhibitors and certain chemotherapy drugs. But that is based on sort of looking at subgroups of clinical trials, not necessarily like trials dedicated at answering that question.
So lobular breast cancer, is that a form of hereditary breast cancer with some sort of gene outside the BRCA? And what are their prognoses? Because that's something that, is not commonly diagnosed, correct?
Well, it's not uncommon actually. Like ductal is the most common type of breast cancer, and then
Right.
lobular is the second most common type. And it's
Okay.
just the difference is just based on that protein expression that I had mentioned. So it doesn't necessarily come with like an underlying gene mutation or anything like that. It's just kind of a different expression of the tumor cell.
Okay. So this question comes from a patient who says that she is currently under abemaciclib. I can't pronounce it.
abemaciclib?
Yeah.
Mhm.
17 months of a 24-month treatment plan. Early on, a dose reduction was required due to diarrhea. Has the Monarch study looked at efficacy following dose reduction?
Yeah, good question. So they did look at the intention to treat population, meaning anyone who did have a dose reduction was included in that analysis. So that tells us that even if they did require a dose reduction, they still did well or still had that benefit. To be honest, like I've adopted the practice of starting sometimes at a reduced dose, just because that first month can be so challenging that sometimes I'll start at a slightly lower dose, and then we have the option of increasing it if we want, just because the diarrhea can be so significant.
Okay. This next question is for younger, under 40, premenopausal patients with hormone-positive cancers, how do you determine when to use tamoxifen versus AI inhibitors? Does having one positive node with the metastases have any impact? I think that's a loaded question, but we can.
Yeah, so for very young women, I had kind of discussed that we know from the soft and tech studies that there's some benefit to suppressing the ovaries. So it does depend a little bit on what the overall risk looks like, but certainly being that young is an additional risk factor. Um, Ovarian suppression is required to use an aromatase inhibitor. We can't use aromatase inhibitors without ovarian suppression. The reason for that is the way that an aromatase inhibitor works is by blocking the production of non-ovarian estrogens. And so if you still have ovaries that are producing estrogen, an aromatase inhibitor actually won't work because it doesn't block those ovarian estrogens. So for very young women, we have to combine ovarian suppression with endocrine therapy to have the achieved effect. When we give women chemotherapy, I think I already mentioned as well that there is a suppressive effect on the ovaries. That isn't always permanent, and so we often will continue to use ovarian suppression even after chemotherapy to ensure that that effect is maintained.
And she asks about having one positive node with the macrometastases. Does that have any impact?
Pardon me?
She asks about having one positive node with macrometastases, and does that have any impact?
Yeah, if there's node positive disease, we would typically use ovarian suppression in that scenario.
So, in summary, are younger women with HER2 with HR positive still getting 5 years of tamoxifen and 5 years of AI?
You mean, so if for young women with hormone receptor positive breast cancer, if they have low risk disease, they may get just tamoxifen alone. And by low risk, I mean like smaller tumors with a lower risk oncotype score. So it depends, I guess is my answer. It really depends on how risky their breast cancer is to say what type of adjuvant treatment they would have.
And that obviously has changed, right? From early years of when they used to just automatically give her HR positive person 5 and 5 years when they were younger.
Right. Yeah, it has changed, right? And using the genomic profiling, in addition to ovarian suppression, as opposed to like tamoxifen, then switch.
Right. Okay. Next question. In a patient post recent treatment for HER2 positive, HR negative, and now presenting with endometrial hypoplasia, is there any risk in using intrauterine progesterone Mirna IUD?
That's a very good question. So, for a woman who has a hormone receptor negative breast cancer, there is no additional risk to using some exogenous estrogen. And of course, like topical estrogen. So we get asked this question commonly for patients who have like vaginal dryness later in life, who have non-estrogen based cancers. Then certainly like topical estrogens are safe. Usually like a Mirena IUD would certainly be a reasonable thing to do. And again, that's sort of like a risk benefit discussion, but in a hormone receptor negative breast cancer, it sounds like it's a reasonable choice to me.
Next question. Is multicentric IDC with one node positive more likely to have a recurrence? Does the combined size of the tumors and oncotype scores affect the treatment?
That's a good question. So the way that we stage breast cancers is based on the size of the largest tumor, not additive. So we risk stratify it according to the largest one. We don't add them all together to get their stage. So the short answer is, we would risk stratify them according to the largest and not combining them all together. But it is something that we take into consideration for local therapy. So like for making surgical decisions, for radiation decisions, but not, if in order to make a systemic therapy decision, we typically use the largest size.
Okay. Next question is regarding metaplastic triple negative breast cancer. This person says she had a lumpectomy, although I wanted a mastectomy, and was offered radiation as the only treatment. Was told my subtype was not responsive to chemotherapy. My question is about follow-up. I have been told unless I have symptoms, I would not get much follow-up. I want to be proactive and find that there is no standard of care treatments for this particular breast cancer.
I guess it's a little bit, hard for me to comment on a specific case, and I wouldn't want to provide misinformation based on limited data points. So sorry, I don't really want to provide like specific advice. That's fair.
Okay, that is fair. The next question is, they would like to know treatments after sentinel node biopsy with non-malignant lymph nodes, tumor 0.9 mm, triple negative breast cancer, grade 2, score 6 and 7.
Sorry, can you ask that again?
So they would like to know about treatments after sentinel node biopsy with non-malignant lymph nodes. They have a tumor of 0.9 mm triple negative breast cancer, grade 2 and score 6 and 7.
I don't know what the score 6 and 7 would mean. So for triple negative breast cancers under 2 centimeters, we do still consider upfront surgery, and usually for tumors around 1 centimeter would consider adjuvant chemotherapy, even with node negative. So it sounds like it's sort of maybe on the cusp of when we would consider adjuvant chemotherapy, but again, it's very hard specific treatment. Yeah.
Okay. Is there certain diets that you would suggest, like high protein, should you reduce weight and inflammation? I guess the question is, would it reduce weight and inflammation? I don't know.
Right. So to be honest, there's no specific breast cancer diet that's been shown to be beneficial over others. And so our dietitians typically recommend to follow Canada's food guide and try to have a healthy, balanced diet from all food groups. Of course, I had also said that we have data to show that maintaining a healthy weight, meaning like within a normal BMI category, can improve breast cancer outcomes. And so I think for each individual, sometimes how you get there is different. Like some people are more successful on a higher protein diet, some people are more successful in other ways. And so there's not a specific diet that I would recommend, but certainly having a healthy, balanced diet is important.
So would you say that the weight is very important, maintaining a good weight and not?
So I
Do you
think it's important.
if that has a lot, is that very impactful on not just breast cancer, but any diseases?
Well, that's what I would say. I think it's probably important as well, just from an overall health perspective, like thinking about cardiovascular risk in particular. Maintaining a healthy weight is really important. Unfortunately, we do have some treatments that have the potential to cause cardiac consequences. And so, as much as we can kind of try to avoid those overlapping toxicities is really important as well. So I think, yeah, primarily from an overall health perspective, it's important. And then there is some data to show that it's beneficial for breast.
So, is there studies that are currently being conducted with both exercise and diet? Because for years, some people have come close enough to say, yes, there is a significant change and a difference, but are they still continuing on that with the, you know?
So like locally here in Calgary, we have an ACE program, which is an exercise program for cancer patients, and they're collecting data, like a lot of the data that's maybe a little bit more easy to collect and be accurate about would be things like quality of life data, overall fitness data. It's sometimes hard to correlate these things with like long-term recurrences. As you can imagine, the amount of confounding factors in a study like that is pretty high. So lifestyle studies correlating with like long-term outcomes are challenging to do prospectively and often are relying on population data, looking at averages and that sort of thing.
Yeah, so that would be hard to gauge. I mean,
Right.
it is a big study. And how do you keep, that study so contained that you could have results over that?
Yeah.
And who would you include, right?
Yeah. Yeah, so that's why I think a lot of the research that's being done locally does have a lot to do with like quality of life, like physiologic things like, muscle mass, those sorts of outcomes. But there is pretty clear data for the joint pain with endocrine therapies being improved with regular exercise. But they are difficult studies to be definitive just because there are so many potential like confounding variables.
And what percentage of your patients would you say stick to a diet and exercise?
The unfortunate answer is I probably don't know. Like maybe it's probably something we should bring up more in our meetings with each other. Um, so it would be hard for me to give a percentage. I think it's, there's many women who already had very healthy lifestyles going into it, and I think majority of those women maintain it. But it's hard to make a lifestyle adjustment while undergoing cancer treatment because you have enough coming at you, right? So
Right.
I guess it would be hard for me to give a number.
Okay. I'll go on to the next question. Do you use only immune therapy for metastatic triple negative breast cancer?
So right now we're using it in triple negative breast cancers in early and in metastatic disease. We do have ongoing studies seeing if we can incorporate it more into our other types of breast cancer. It hasn't yet been super successful for the other subtypes of breast cancer, but certainly we're looking at some combination therapy approaches and things like that to see if we can be using it in other subtypes.
And can you explain the immunotherapy and how does that work? What kind of regimen is it?
Yeah, so it's a very in early stage triple negative breast cancer, it's an intense regimen. So you get 4 cycles of chemotherapy every 3 weeks or weekly, with the immune therapy given every 3 weeks for 12 weeks. And then you go on for an every 3 weekly cycle for an additional 12 weeks. So it's like 24 weeks that you're getting chemotherapy plus immune therapy. Um, the immune therapy, because it kind of activates your immune system, has some autoimmune type effects. So sometimes people on immune therapy could get an immune mediated like diarrhea. Sometimes there's a rash. It can affect your thyroid function. It can affect your pancreas. Like it can cause things like hyperglycemia and diabetes. So it can really affect any part of the body. And we can monitor it on blood work and make sure that everything is safe. But it's not an easy treatment by any means.
And for triple negative diagnoses, do you usually do treatment, then surgery, and then follow-up treatment if necessary? Is that usually the plan and why?
Well, like I had mentioned, there's a lot of data to show that how good a person's response is to preoperative treatment is prognostic into how they'll do longer term. So the immune therapy is only approved in preoperative treatment. So the way that the study was designed, it was given preoperatively. And so, as you know, like when a study is designed that way, that's how we'll use it. So to get access to immune therapy, it has to be given preoperatively. And then we can use their response to treatment as a way to guide our subsequent therapy. So for women who have a complete response, they may complete that year of pembrolizumab, or they may stop treatment at that point, because we know that with a complete pathologic response, their outcome is going to be excellent. With residual disease, we know they're at a little bit higher risk, and so we add additional adjuvant treatments to kind of counteract that risk.
So when you're giving the patient all those treatments, do they give a little bit of break? Because I would imagine that from what I understand, they're really exhausted from those treatments, and then they have to undergo surgery. You can only imagine that whole, journey.
Yeah, it's a lot, right? Like that's 6 months of treatment, then surgery, then more chemo plus maybe radiation. So I would like to say they get a long break, but probably only like, 4 to 6 weeks, maybe again. Usually like 4 before we would be talking about more chemo. So it certainly is not easy, and it's long. So there is a lot of toxicity for sure.
Okay, so the next question, what about cardiotoxicity and Herceptin? Can a delay in treatment cause greater chance of recurrence?
Mhm. So the interesting thing about the cardiotoxicity with Herceptin is that it typically is reversible. So with time off treatment, it does tend to improve, and then often we can restart it without any further cardiac consequences. The majority of treatment delays do not affect outcomes, and so, like I had mentioned, all of the studies, when they show that there's a benefit, look at the patients in with the intention to treat model, meaning that whether they stayed to the exact course or didn't, they were still included in that analysis. And so it's pretty common to have treatment delays and dose reductions and things like that along the course of our treatment, and we know that it's still effective.
Yeah, and I guess that patients get worried about that, right?
Of
Because
course.
they want to
Yeah.
continue and they don't want to break, because they're
Mhm.
assuming that if they break, things just don't, get
Mhm.
done properly, right? So
Totally. But I
it is,
think
yeah,
it's like safety is paramount, right? And
yes,
especially when we're giving a person a preventative treatment of something that's already unlikely to happen, we have to be cautious not to cause long-term harm. So I think, it is a balance, right, between wanting to be super aggressive, but also wanting to be aware of those, potential toxicities.
right. The next question is someone who has triple negative breast cancer. Treatment was done last year, I guess finished last year. She's not on any meds. Going forward, is there specific advice for triple negative patients?
Mm. So there's not specific advice actually. Depending on what type of surgery a person has, we would recommend annual breast imaging. So that would be at least with a diagnostic mammogram, plus or minus an ultrasound, depending on how dense your breasts are. Um, we've never been able to show a benefit for routine surveillance imaging for breast cancer patients, meaning studies in the past that have looked at should we do CT scans and bone scans every 3 months or 6 months, never demonstrated that we were able to pick up recurrences early as a result of having done that. And so, for that reason, our follow up is symptom guided. So, our patients should all be seeing a physician, whether they're oncologists or their family doctors, every 6 months for an evaluation, including a physical exam um, and and uh, and blood work. There's no tumor marker either for breast cancer, right? So there's nothing that we can test in your blood that reliably tells us, do we have to worry there's a recurrence, yes or no? And so we do rely on symptoms to kind of help guide our investigations.
Is that for all breast cancers?
Yeah.
Wow,
Hmm.
that's pretty scary. Unless people are in a study or a clinical trial? I guess they get,
Most clinical trials don't do like surveillance imaging after. But we do image. I would say like your threshold to image is low, right? So if I had a patient who had a breast cancer that came and told me, I have a pain that's never going away, it's kind of waking me up at night sometimes, I would order them a CT scan right away. So I think that's the way that you pick things up, is by, knowing your body, knowing when something's different and doesn't feel right, and you can see your doctor and they would order the appropriate investigations.
yeah, it's tough because that could be very scary, second guessing for patients. They can wait too long or they can go too fast to a
So I'll
doctor.
tell you that this is a very
Hard.
common conversation for, and so people ask me this all the time, right? Like, well, what am I looking out for? And so what I would usually say is an example would be pain, right? But then, like you said, we all have pain, and pain comes and goes. It's sometimes here, sometimes there. Pain that's less common would be pain that never goes away, that only gets progressively worse, and pain that wakes you up in the middle of the night. So, it's kind of normal to wake up and notice you have pain. It would be less normal to be woken from a comfortable sleep because of pain. And the
Yeah,
other thing I always say to my patients is, I would rather you tell me about nothing than not tell me about something. Meaning, I would rather, if you're wondering, just tell me, and then we can decide together if it's worth investigating or not. Because it shouldn't be left waiting and wondering. If you're worried, you let me know and we investigate it.
right. I'm going to go with this last question and then we're really up for the finale of all this, which was fantastic. So this person is a newly diagnosed patient with stage 2, grade 2, HR positive, HER2 negative, low +1, with 1 positive node. Are there treatments available using targeted therapy, or would standard chemotherapy be effective? I had a mastectomy July 16th, she writes, and I am still waiting to see oncologist.
I'm sorry, that's a long wait.
Yeah.
Um, and so I missed a few of the details. And so the caveat to some of these answers, of course, is like it's hard for me to make medical recommendations on limited information. So if I say something and your oncologist says something different, it's because they have more information, and I would trust their opinion completely. But it sounded like a hormone receptor positive,
HER2 negative,
HER2 negative.
low +1. I don't know what low +1 is.
So the way that we measure HER2 has changed recently.
Oh, right.
It affects metastatic breast cancer more than it does early stage breast cancer, because we're not using those treatments in early stage breast cancer yet. So in terms of targeted therapies, not really without an underlying gene mutation, apart from maybe a CDK4/6 inhibitor. But with node negative breast cancers, we're not routinely using them yet either. So the standard of care therapies like chemotherapy and anti-estrogen based therapies are really effective, particularly for that type of breast cancer.
Yeah, and it's hard to address this without knowing the patient. And just to correct you, she has 1 positive node.
Oh, okay. Yeah. So that
Just
may be an
that,
option.
yeah, yeah. Okay, so do you have any final thoughts and words about, what's going in pipelines and how to, what words of wisdom can you finish this before I conclude the session today?
Yeah, so it sounds like everyone has very good questions, and that's excellent. I think, like I had mentioned, really the treatment of breast cancer is moving towards targeting therapy towards individual risk, and trying to be as individualized and as specific as we can be about what that risk looks like. I tried my best to answer the specific questions, but I apologize if the specific case advice was not the best, but
Right.
I think in broad terms it was about right.
Yeah. Well, I really want to thank you. You really did a phenomenal job. And I think just based on the questions, it was
Yeah,
very
very
engaging
thoughtful
and
question.
a lot
Thank
of, lot of good question. So with that, it concludes our time for today's session. Thank you everyone for your questions and for joining us to learn about recent advancement in treatments, care, and research for early stage breast cancer. Thank you again to Dr. Nixon for being here with us today. Thank you again to our sponsors, Novartis, Pfizer, Gilead, AstraZeneca, Merck, and Daiichi Sankyo. Following this session, you will get a link to complete a survey to provide feedback on this session. Please consider leaving feedback, as this really helps us to improve future sessions for attendees like yourself. And again, thank you and have a wonderful afternoon.
Thank you.